from Matunga as well as Sayan.
Mhm.
Without much ado, may I request Dr. Atul Devsi to take over the proceedings? Thank you.
Good afternoon, everybody. Thank you, Dr. Bhatt sir and Dr. Dolakia sir. We today's chairperson we have Dr. Ajita Bhosle. She is practicing at Kandivali, physician clinician with special interest in non-invasive cardiology and diabetology. Focuses on preventive medicine and holistic approach in patient or treating patient. Yes, madam. Over to you, madam.
Thank you so much, Dr. Atul Doshi, sir. Good afternoon, everyone. I welcome you all for today's academic session on obesity management. Obesity has emerged as one of the most significant public health challenge of our time, with far-reaching metabolic, cardiovascular, and psychosocial consequences. To guide us on this, we have our expert speaker for today, Dr. Jaydeep Palep. Dr. Jaydeep Palep is a senior consultant, GI and bariatric surgeon at Breach Candy, Jaslok, Sefi, Bhatia, PD Hinduja, and Leelavati Hospital. He's the only surgeon in Western India doing robotic GI and bariatric surgery for over 16 years. He is also a director of Dr. Palep's Weight Loss and Gastro Clinic. Welcome, Dr. Jaydeep Palep, sir.
Hi, very good afternoon, everyone, and thank you very much for inviting me this afternoon to this webinar, which has been going on for such a long time. And thanks to Dr. Dolakia and Jaslok Hospital and Avinash for having me over today. Without much ado, I would like to just share my screen so that we can start the presentation. Can you see the screen?
Yeah, yeah.
Yeah. All right. So I'm just going to begin this session, and if you have any questions, you can probably put them in the chat box, and then we can take it from there. All right. So I'm just going to um, talk about diabetes. Now, obesity, everybody knows the term obesity. But when it comes to a combination of type 2 diabetes with obesity, the term coined has been diabetes. Now, why diabetes? Let's go down to the basics first. India is, as a country, the global capital of type 2 diabetes mellitus. And I think we are all aware of that. All you family physicians see that in your day-to-day practice that a lot of your patients have contracted this disease, diabetes, and majority of the patients who are suffering from diabetes are overweight or obese diabetic. So what happens in all these patients is that they suffer from something called the metabolic syndrome, where you will see that they all have visceral obesity, insulin resistance, hypertension, low HDL, which is the good cholesterol, and a raised triglyceride level, which is the bad cholesterol. All these five in combination basically form the metabolic syndrome. And that is what is the genesis of this diabetes as far as the Indian population is concerned. And this is actually a very scary thing as far as India is concerned, and which is why I think Dr. Ajita Bhosle started with the fact that the incidence of obesity has grown in such vast proportions in our country that it has actually reached alarming scales, which is why um our system in India, as far as healthcare is concerned, the central government is concerned, they have recognized obesity as a chronic illness and it needs to be looked into very urgently and seriously. So, this is the global picture of diabetes, which is a global problem as far as the whole world is concerned. And if you can see the markings here, Africa, Europe, Middle East, and North Africa, and all these countries, Southeast Asia, every part of the world, there is a lot of obesity, which is being really on the rise, especially over the last 2 decades. When you talk about me as a bariatric surgeon, what do we see as bariatric surgeons across the world? That if This is the population of morbidly obese people, that's 370 to 560 million with type 2 diabetes. Only 0.1 to 0.15% of them have undergone or have been offered bariatric surgery because of the lack of awareness, because of the lack of insight into the fact that obesity is such a chronic problem and such a chronic deadly disease. So what is I will come back to obesity per se generalized later on, but I will talk a little about metabolic bariatric surgery. We stopped calling it bariatric surgery anymore, and for the last at least more than 3 years, the term has been metabolic bariatric surgery, which refers to surgical procedures which are primarily aimed at treating metabolic diseases, especially type 2 diabetes, obesity, and its related comorbidities by altering the gastrointestinal anatomy. And I'm going to talk about this because a lot of what is happening today in terms of treatment of obesity with respect to GLP-1 receptor agonists that all of you are eager to hear about is based on bariatric surgery. While these procedures were originally developed for weight loss, their profound effects on the glucose metabolism, hormonal regulation, and insulin sensitivity have made them a key therapeutic tool in the management of metabolic disorders. So, this is very crucial: glucose metabolism, hormonal regulation, and insulin sensitivity. And this is where the connection with GLP-1 RA and the currently available medication for obesity or AOMs, anti-obesity management drugs, is related very deeply. Okay, I'll go back to 1995 when one of the first papers which was published in the New England Journal of Medicine was written by a surgeon called Walter Porres. And he is a bariatric surgeon. He's very, very old now. He's more than 90 plus. And this article was published in 1995 and nobody had even heard of bariatric surgery in our country. And he had written there that there's a strong relationship between obesity and type 2 diabetes, and the term diabesity has been coined to suggest a single problem. This is published in 1995. We are in 2026. So that's like 30 years, more than 30 years back. Okay. And frankly, how many of us were even aware of such a term called diabesity back then? This is Walter Porres and Henry Buchwald, and that's me. I was lucky enough to meet them at a couple of conferences of bariatric surgery. And Walter Porres very famously had said that we can now say with confidence that diabetes is a surgically curable disease. And Henry Buchwald said that surgery is not just about cutting fat, it's about altering the metabolism, saving lives, and changing the course of the disease. So, these are two great pioneers of metabolic surgery in the world who had published and predicted this many, many years back about the role of GLP-1 in bariatric surgery. And that is also the genesis of the drug GLP-1 in its case, semaglutide and tirzepatide, which we will talk about later on. So, BMI and obesity and the WHO criteria. So let's come down back to how obesity is classified world over, but we will mostly concentrate on Asians. And you see that for the Asian population, a normal BMI is 18.5 to 23. Anybody who is more than 23 and less than 27 and a half is considered overweight. Anybody who is more than 27 and a half and in less than 32 and a half is considered a class 1 obese individual. And anybody who is ranging between 32 and a half to 37 and a half is class 2. And anybody more than 37 and a half is class 3 obese or very severely obese. So we are looking at moderate, severe, very severe, and critical obesity. And the lower cutoffs for Asians is because of increased risk of cardiovascular disease. The belly fat that all Asians have is one of the biggest risk factors for cardiovascular events and cardiovascular disease and diabetes at much lower levels of obesity in comparison to the whites or the Caucasians and the blacks, the African population. Okay. So, in terms of current day management and the guidelines which have been published, this is from a peer-reviewed journal called Endocrine Practice, and it very clearly mentions these guidelines. This is a very important slide, and you might want to take a screenshot of the slide or whatever and keep it so that you know the right indications for your patient when your patient comes asking for medication for obesity. So there's lifestyle modification, which obviously is required for every BMI group subgroup, whether it is more than 40 BMI or between 25 and 27 BMI. Pharmacotherapy, you start only after somebody crosses a BMI of 27, and it can go to any BMI where you can offer pharmacotherapy today with the advent of GLP-1 receptor agonists like semaglutide and tirzepatide. And surgery essentially is offered world over, especially in Asia, to anybody who is a BMI of more than 30 going all the way upward. The insurance guidelines for IRDAI, that is the Indian Insurance Regulatory Authority of India, says that anybody above a BMI of 40 will clearly get insurance or mediclaim cover for bariatric surgery. Anybody less than 40 but more than 35 with medical comorbidities will also get mediclaim for bariatric surgery. So these are two figures which you need to know very, very clearly, that if your patient is asking for bariatric surgery and asking you the question that is it covered in mediclaim, the cutoff figures are 40 plus and between 35 and 40 with one medical comorbidity for which he requires medical attention. All right. So that is the criteria for surgery. But lifestyle modification, every single category of patient has to have a healthy lifestyle, which includes a healthy diet, which is rich in protein, very low in carbs and fried foods, and also an exercise regime where he or she should be exercising or putting in at least 40 to 45 minutes of physical activity 5 times a week out of 7 days. All right. So this is a very crucial slide. So is surgery the answer for everyone? I've just mentioned to you on the slide that anybody above 40 for Indian patients and anybody between 35 and 40 are definitely candidates, and they do far better as far as total body weight loss is concerned and as far as medical comorbidity resolution is also concerned. Okay. And after bariatric surgery, we have seen world over and published data shows resolution and improvement in 85 to 90% of diabetes, improvement in dyslipidemia by more than 70%, resolved hypertension or improvement in their blood pressure scores of 85.7%, 90% resolution or improved OSA, 60 to 7% reduction of dose for hypothyroids, and definitely better chances of avoiding surgeries like TKR for patients who are suffering from knee joint osteoarthritis. This is all published literature. Okay. The criteria that we follow, anybody more than 15, less than 65. Technically, now that 65 has already been raised to 75 because people are living longer, and longevity has, because of better healthcare facilities, has taken our upper age limit from 65 to 75. And for females more than 12 years of age, because they attain menarche and they have completed their bone growth, we do offer surgeries to them. And males, because they have a delayed growth spurt, which is normally after 17, is only when that we offer bariatric surgery for these patients. Okay, I've already discussed the the BMI guidelines, so I won't go back into it. Now, this is a flow chart which you might want to take a picture from your laptop, screenshot, or on your phone, or whatever you like. And this will give you a very clear-cut indication when a patient is sitting across you on the table in your consulting room, as to who is that person, whether and what kind of treatment you want to offer that particular patient. Okay, there are a lot of different types of bariatric surgeries, but I won't go into that. I will just broadly classify them as restrictive surgeries and malabsorptive surgeries, or a combination of both. The commonest surgeries that I perform in practice are the sleeve gastrectomy, the gastric bypass, and different types of gastric bypasses. And in fact, at Jaslok now, I am doing all these surgeries robotic for the last few years with exceptional results, with really great outcomes. And as of today, with as good as zero complications ever since we have started doing robotic bariatric surgery at Jaslok Hospital. Okay, so that's a very crucial thing. We have some of the best insurance cover for all bariatric surgeries in Jaslok also. Pretty much every single patient till date has got Mediclaim completely cashless in Jaslok Hospital for all my patients. So please remember this very clearly that the tie-ups that we have as far as insurance is concerned in Jaslok Hospital are probably the best in the city. I don't think any other hospital can even compare or come close to that in terms of the number of insurance tie-ups that we have at Jaslok Hospital. So no patient has till date been rejected or not had the benefit of getting a cashless claim for bariatric or any other robotic surgery at Jaslok Hospital. So this is a sleeve gastrectomy. It's just basically a schematic representation. This is your normal stomach. What we essentially do is devascularize the greater curvature of the stomach and then get a stapler inside and fire this stapler along a bougie which we pass through the esophagus, which the anesthetist passes. And the shape of the new stomach is just like the bougie over the bougie, and it looks like the esophagus and the continuation of the esophagus. It's a restrictive procedure, and it gives you an effective total body weight loss of roughly around 40%, which is really good for adolescents, which is really good for young adults, which is really good for females who are not married. Sleeve gastrectomy is the most performed procedure world over and has stood the test of time as a standalone metabolic bariatric procedure. Then comes the gastric bypass. The gastric bypass again has been performed world over since the 1960s. So it has the largest amount of database of patients and patient volumes world over, where we create a small stomach pouch, and it is only a 40 to 50 cc pouch as against a sleeve gastrectomy, which is a 80 to 100 ml pouch. And the food goes in from there and goes straight into the jejunum, which we have brought up there and made a gastrojejunostomy. And the digestive juices come back down from here and go into the jejunum, and there is a jejunostomy here. So there is one anastomosis here and one anastomosis here. So this is the segment which is bypassed from food, and this is the segment which is bypassed from the juices, and that is why it's a very potent procedure for weight loss as well as resolution of comorbidities. Then there is OAGB, or one anastomosis gastric bypass. Usually I perform this for my non-vegetarian eating patients who can consume a lot of meat and eggs in their daily diet, because this is a very severely malabsorptive procedure in comparison to the gastric bypass. And we perform an anastomosis of the stomach with the jejunum, but this entire portion of the antrum and D1 is bypassed. So that gives rise to micronutrient absorption loss, which is why we need to have patients who can really consume a lot of non-veg. So a lot of my patients who are Africans and Arabs from the Middle East, I prefer using this procedure for them. It gives you beautiful resolution of type 2 diabetes also. Then there is sleeve plus procedures, and there is a whole variety of procedures here, but I don't want to confuse you with that. Each procedure is customized for an individual. I don't offer the same procedure for every patient. It has to be customized to every patient's metabolic needs and the weight and BMI criteria. Okay, so once I'm clear about all the preoperative investigation, only then will I offer a procedure. Okay, so to summarize it, most diabetics who are obese will either land up with a bypass or an amputation or go with CKD on dialysis, will have a lot of neurological problems with multiple admissions, multiple IV antibiotic admissions, all these things because of diabetes and morbid obesity, leading to so many other medical problems, vis-a-vis performing or undergoing one metabolic bariatric surgery, which will give you long-term resolution for all these problems and save a lot of money and financial burden on the family. Obviously, it is needless to say that there is a great improvement in quality of life, well-being, body self-image, self-confidence, etc. Now, coming to endoscopic interventions. Now, there are a lot of talk about endoscopic sleeve, intragastric balloons, but all these things are temporary. The moment the effect of this particular procedure goes away, then the problem is that the weight can regain. So, in medical literature currently, we are not seeing really great benefits of endoscopic weight loss solution like endoscopic sleeve or the Allurian swallow pill, where you can just swallow a capsule which can actually be inflated inside your stomach as you swallowed it, and eventually that balloon gets absorbed by the body in 16 weeks. So the weight loss process is happening only for 16 weeks. And in an endoscopic sleeve, it can last for a year or so, because mind you that the stomach has continuous peristalsis, and the stitches that we take from inside in an endoscopic sleeve can get disrupted and break, because the stomach is your mixer grinder. So the mixer grinder keeps churning all day, all night long whenever there is any stimulus of food, and those stitches will keep breaking because of the constant wear and tear. So the endoscopic sleeve is a very short-lived procedure with short-lived benefits. So it's not a great procedure to be recommended, but there are some patients who are hell-bent on saying that I don't want bariatric surgery at all. So they will undergo an endoscopic sleeve. And then the other ones who don't even want an endoscopic sleeve will take the Allurian pill or the swallow pill, where you can just swallow the tablet, the capsule, and then we inject the capsule and with saline of 400 ml or 500 ml, and it just fills up your stomach like a space occupying lesion, and you can only eat so much that once the stomach hits the roof or the fundus, you will feel full and you won't be able to eat. And like I said, it gets dissolved automatically in 16 weeks and it passes off in your stool. So the 17th week, the weight loss effect will be gone and your stomach will be back to its original size. Okay, so these are the endoscopic solutions. Now, coming back to the original algorithm of lifestyle modification, pharmacotherapy, and surgery, and anti-obesity medications, which all of you were interested in listening to today, and why GLP-1 is a game changer. Why is metabolic surgery, how metabolic surgery related to this? So when bariatric surgery came into being and scientists realized that it is the GLP-1 which is being secreted by the terminal ileum, GLP-1 and GIP, those are the two hormones which are actually causing the weight loss also and the resolution of diabetes also. And then they decided that why not manufacture it artificially and give it to patients directly, and thus were born tirzepatide and semaglutide. So the scientists and the pharma industry have to thank bariatric surgeons for the discovery of tirzepatide and semaglutide as drugs which we know today in the market as Mounjaro and Ozempic. So tirzepatide is Mounjaro and semaglutide is Ozempic. So tirzepatide is a combination of GLP-1 and GIP, and whereas semaglutide is only GLP-1. And that brings us back to 1995 and the article that I showed you up front earlier. This is where the genesis of everything started in today's times. This is Mounjaro, Ozempic, and oral Ozempic, which is Ribelsus, which has actually failed to take off because of poor patient compliance. But we'll talk about Mounjaro and Ozempic now. Okay. Now, everybody in their day-to-day practice, whether it is family physicians, MD physicians, diabetologists, endocrinologists, gynecologists, suddenly everybody started treating obesity. Before the advent of these drugs, none of the physicians was treating obesity except probably endocrinologists, because the drugs available back then were showing great side effects with very minimal weight loss results. And bariatric surgeons have been treating morbid obesity and obesity for more than 3 decades now. In my practice, I myself am treating morbid obesity for almost 20 years now. It's 19 years since I started practicing obesity surgery in India, in Mumbai. But now, because of these two magic drugs, as they call it, every person is becoming an obesity expert and is treating obesity, and I'm sure all of you would agree with that. So what is semaglutide doing? Semaglutide is a human GLP-1 analog. It is almost 94% similar to the human GLP-1. The half-life is 1 week. That is why the patients have to be given an injection every weekly. Okay, so once they start taking this and they are on this dose Monday to Monday or Sunday to Sunday, they have to take one. So what happens is basically there is a direct activation of the hypothalamus. Basically your satiety centers, your hedonistic center, your hunger, feeling of fullness, and the cravings of hunger all are in the hindbrain and in the hypothalamus. And this is where the GLP-1 directly goes and attacks, and GLP-1 receptor agonists, and they go and bind all these receptors and they plug them. So the cravings go down, the satiety comes faster. Okay, and that is what is the main mechanism of action of these drugs. So you have Wegovy 2.4 milligram, which is working on the homeostatic regulation and the hedonic regulation. So basically, it is increasing the satiety, making a patient feel less hunger, and it is also reducing the food cravings, which means that so there are even food preferences which have started developing after patients have gone on these drugs, that they suddenly stop liking a lot of things which they used to like junk food and stuff. So they just see them and they feel nauseous and they don't feel like taking them. Okay. And similarly with Monjaro, which is tirzepatide, if you're taking Monjaro and Ozempic, the increase in doses is after every month. So every 4 doses the patient tolerates, then you go to the next dose. All right. So it can be zero point 0.5 to 0.7 to 1 to 1.5 to 2.4 in Wegovy, and similarly starting from 2.4 going all the way to 14 in Monjaro. Okay, one thing which you need to remember when you are prescribing this as a doctor to your patients in Munjaro or in Ozempic, when you're treating them or when they are already taking SGLT2 inhibitors for diabetes, the or metformin, Munjaro can be continued in the same form because they are primarily anti-diabetic drugs. Please remember that both these drugs are anti-diabetic drugs. They were first given FDA approval for treatment of type 2 diabetes and not for obesity. Okay, that was an adjunct and that came later on. But if the patient is on insulin or sulfonylurea, then you need a reduction in the dose of the sulfonylurea or insulin. Otherwise, there is a risk of hypoglycemia. And the patient should have blood glucose self monitoring equipment, which is definitely necessary to titrate the doses of sulfonylurea and insulin. And then there should be a stepwise approach to the reduction with the help of the endocrinologist, diabetologist, or physician, or whoever is treating them for their diabetes. And there is no adjustment of dose required for age, gender, race, ethnicity, or body weight. It is definitely a contraindication for anybody below 18 years. It has not been tried. So please don't give it to anybody who is less than 18 years of age, male or female. Okay, there is no dose adjustment which is required in patients with hepatic or renal impairment because they are both safe for liver and kidney. And the experience with the use of Munjaro in patients with end-stage renal disease and severe hepatic impairment is very limited. So you have to exercise a great caution in prescribing it to any of these patients. All right. Again, practical considerations for your patient, whether it is Munjaro or Ozempic, it is a straightaway contraindication for anybody who suffered from acute pancreatitis, whether it is because of gallstones or whether it is because of alcohol or any other reason. None of these drugs have been tried on pregnant women, so please don't just make sure that the woman who's asking for it is not pregnant because you will land up with a totally different set of medical legal issues. And even breastfeeding mothers, you cannot give it to them because there are no studies conducted so far to know what is the effect of any of these drugs being secreted in the milk and passing on to the baby. All right. And diabetic retinopathy again is a contraindication. So basically, after all this, where do we stand today? Like I said, 25 to 30 BMI, lifestyle changes. You can give any of these medications. 30 to 35, lifestyle changes, medication. They may consider endoscopy treatment if they don't want surgery or metabolic bariatric surgery. And anybody above this, again, the same spectrum, but basically anyone who is more than 40 BMI, the clear answer is metabolic bariatric surgery, and one must customize the approach for every individual as far as treatment for obesity is concerned. The bariatric surgeon who practices metabolic bariatric surgery is actually the obese patient's barrow buddy, as we call it, because we have been there for the longest time supporting obese people in management, whether it has been non-surgical or surgical management, by providing them with support, guidance, sharing experiences of other patients. We are always there to troubleshoot and provide practical tips and encouragement. And we have bariatric support groups, whether they are operated patients or patients who are on injectables. We have support group meetings of our patients so that they can mingle with each other and draw from each other's experiences. So that is why we are the Barrow buddies for the obese patients who come to treat or come for a solution for their obesity. Thank you very much for a patient hearing. And if you have any questions, I will be most happy to take it. I hope I was audible.
Sir, whom
Yes,
to
sir.
offer this? Yeah. Whom to offer the Ozempic and this Manjaro?
Sorry?
Even non-diabetic can have it.
Non-diabetic and?
Anyone non-diabetic can take this or Manjaro and this thing.
Yes. Basically, it is being prescribed purely as a weight loss medication, irrespective of whether you have diabetes or we don't have diabetes. It has got US FDA approval and Indian FDA approval for the given doses which are currently available in the market, whether it is Ozempic or whether it is Mounjaro. Both can be given to patients who are just suffering from obesity.
If they don't go in hypoglycemia,
No, that's what. So the doses have been altered from the doses that were being given for diabetes. They've been brought down for the obesity, and that is why it is being given. The same dose has to be continued for a 4-week period. You have to have the patient come back to you to see if they suffered from any side effects, whether it is hypoglycemia, whether it is gastrointestinal side effects like diarrhea or constipation or nausea, or because both these drugs can cause a lot of gastroparesis, okay, in some patients. I currently must be having around at least 30 odd patients between Ozempic and Mounjaro, taking one of these drugs. But so far, nobody has come up with any GI side effects as of now. But the doses have to be titrated once every 4 weeks only. The 5th week, you can increase the dose. If the patient is not tolerating that dose, you come back to the lower dose. That is what is the recommendation.
long-term effect of osteoporosis has a for the osteoporosis.
Yeah. So, see, that is where the whole challenge is, a lot of people are prescribing these drugs without any nutritional supplements. In any patient who has undergone a metabolic bariatric surgery by us, we always give them for life multivitamin, calcium, iron, and high protein diet, and vitamin D once in a month. First once in a week for 8 weeks, and then once in a month. All these things are same and have to be maintained even if the patient is going on Ozempic or Mounjaro. That is what most physicians are not doing. They're just giving Ozempic and Mounjaro. So there's going to be sarcopenia, there is going to be osteoporosis. If you're not supplementing and if you're not informing your patient that these things are essential and required, it's going to land up the patient in big problems in a year down the line or 2 years down the line.
How much weight
Thyroid
reduction we
tumor.
expect? How much weight reduction in a week? 0.5%, 1%, how much we can expect?
No, so every person is behaving in a different manner. But on an average, what I have seen is that patients are losing anywhere between 1 to 3 kilos a week. And in 4 weeks, every month, I am seeing patients losing anywhere between 2 to 5 kilos.
Okay.
And it differs from
Yeah.
different people. Somebody was asking about thyroid tumors, and
Yes, sir.
there is a possibility. There are some case reports which have been published, and which have come up in light, and there are some lawsuits also. So anybody who has suffered from any thyroid issues and thyroid illnesses in the past and is on medication needs to be evaluated by an endocrinologist before starting this medication. Otherwise,
Correct.
it's a contraindication.
Okay. Yes, same thing. The Kamlesh, Dr. Kamlesh has asked side effects of GLP-1 cause a lot of side effects, including, like as you said, sir, muscle loss and everything,
Correct.
sarcopenia and all. Yeah.
Correct.
There's one
That
more
is why
question.
protein supplementation is very crucial.
Correct.
1
Yes.
gram per kg body weight is the average intake of protein. And if you see, majority of our patients in India are predominantly vegetarian. Even if they say they are non-vegetarian or they eat non-veg, their non-veg
Correct.
eating means it's once or twice in a week.
Correct.
So essentially, predominantly, we are looking at a vegetarian population. So
Correct.
protein replacement is a must.
Must. With There's one more question. So with the increasing of use of GLP-1 receptor agonist and dual agonist, how are you positioning this pediatric surgery? Earlier, later, or combination therapy?
Okay, that's a very, very nice question. So, like I said, anybody who is coming to me with a BMI of more than
40.
40, uh, I offer them bariatric surgery. If they're receptive to hearing about bariatric surgery, I try to educate them about bariatric surgery. Anybody less than 40, more than 35 with multiple medical problems, I try to get them to talk to some of the patients who have undergone the surgery. And then ask them to make an informed decision. If they're still not willing, then we put them on GLP-1 RA, whether it is Ozempic or Munjaro, depending on what the patient fits the bill for. There are patients who I have seen in the last 1.5 years who I have put because they were not willing for surgery, although they were candidates of for surgery, who were 45 BMI, 50 BMI, but still went on the drug, came back in 6 weeks and said that no, I am not comfortable taking these drugs because my day-to-day lifestyle is being hampered. I'm feeling nauseous sometimes. Sometimes I'm feeling less energetic. And the weight loss is really, really slow. So I want to undergo bariatric surgery. So that has also happened.
Correct, sir. Sir, before putting the patient on these drugs, what investigation should be done, sir?
So we have a list of preoperative investigation that we use for bariatric surgery. So we have been using that. Along with that, we also get the urinary creatinine and eGFR values to make sure that the kidney is functioning properly. And a very strong history taking is important
Okay,
before
sir.
we start the drug. Because sometimes, something like gallstone pancreatitis, which I mentioned, patient may have
Yes,
undergone
sir.
a cholecystectomy. We don't know that whether the patient suffered from a gallstone pancreatitis before the cholecystectomy or not. And if you have not asked that, and the patient had suffered from pancreatitis even once, 10 years back, then the pancreas is susceptible for another attack.
Yes, sir. We'll be in trouble, sir. Yes. So there's one more question from Dr. Rene. Role of pediatric surgery in pediatric age group with morbid obesity.
So bariatric surgery, basically, like I mentioned in one of my slides earlier, we offer to boys who have attained puberty and girls who have attained puberty, again
Yes.
menarche. So 17 plus and 12 plus. But there are certain cases where babies or small children come with Prader-Willi syndrome and they become really, really big, and there is no other option but to offer. So the only procedure which qualifies for such a patient who is not fitting the age criteria is in the pediatric age group is a sleeve gastrectomy, because a sleeve gastrectomy will not hamper bone growth even in the later years of life, and the child will still grow and become a normal adult, because it is not a malabsorptive surgery, it is purely a restrictive surgery.
Okay. So the long-term side effects of this GLP-1.
So I think as of right now, the data that is available is only of 7 years for Mounjaro and around 5.5 years of Ozempic or Wegovy
Okay.
in the market since they have been released. So we have only data for that much. We don't have data more than that. And so far, it seems to be relatively safe on all counts.
Okay, sir. There's one more question. Are you seeing any long-term differences in metabolic durability or nutritional complication between sleeve and bypass that are influencing your procedure choice now?
So most of my surgery, again, that's a very intelligent question. Whoever has asked it, I'm really happy that that person has asked this question. What we do normally over the years is that we learn from our own experience and experiences of our colleagues, and especially in India. And we have a large data of patients' outcomes in India, pooled by all our surgeons together under our association. And what we have seen is that predominantly sleeve is the winner in this, because the less malabsorptive procedure you do, the more beneficial it is in the long run to the patient. So you will get weight loss also. At the same time, you will get resolution of medical comorbidities, but you will not get the harmful effects of malabsorptions.
Okay, sir. So, Dolake sir, any more questions?
Yeah. So, sir, in a routine time, we say more than 2 kilo or 3 kilos should not be reduced in obesity. Here, here we get 4 kilo, 5 kilo reduction. How?
No, there is no such hard and fast number that one can say that you should not lose. The one important thing here which needs to be remembered, whether we are offering a bariatric surgery to a patient or any of these injectable drugs to the patient, is that rapid weight loss is only going to form gallbladder stones. That is one of the biggest risks of rapid weight loss, and that is why we start all our patients on ursodeoxycholic acid, or what you know as Udiliv or Ursogreat. In the market,
Yeah.
it comes as Udiliv or Ursogreat. And
Udiliv.
this has to be given 1 BD for 6 months to any patient who is on anti-obesity medication treatment or has undergone bariatric surgery. Because that rapid weight loss which happens in the first 6 months in bariatric surgery, or with the help of Mounjaro or Ozempic, as we keep increasing the dose every month for the first 6 months, is going to cause formation of gallbladder stones.
Okay.
So always remember that to supplement your patient with ursodeoxycholic acid, 1 BD for 6 months straight away.
Yes.
So now
Doc-
some diabetology session come out, zero insulin, from 150 to zero insulin, with weight reduction and lifestyle, all these things.
That's
How far
that's
it is?
possible. I can totally believe that. For somebody who's say BMI of 26, 27 and was on insulin, and you put the patient on Ozempic or Mounjaro, he's going to have weight loss also. So the abdominal fat is
Not,
going to go
not
down. The
Munjaro,
waist
need our, without this drug. They are doing
without.
without this drug, with exercise and loss of diet and all these things.
So if the diabetes is new form in the body, okay, suppose you've been detected for with type 2 diabetes, and that diabetes is only 0 to 6 months old in your body, and you change your lifestyle completely, go to a healthy form of lifestyle, do regular exercises, stick to a very healthy diet, that's possible.
But now some
That-
But
people coming
if
with
the
diabetes.
pancreatic reserve has gone down over a period of time, and you have
Yeah.
diabetes for say 2 years,
10 years,
5
15
years,
years, yeah.
7 years, then it's not going to happen.
Dr. Kamlesh Jariwala has asked, after sleeve gastrectomy, if you go back to old eating habits, does the stomach regain in size?
Yes, 100%. The weight regain in our patients who have undergone a bariatric surgery is at least 15 to 20%. So 100 patients get surgery done, 15 to 20% are going to regain weight in the long run in 2 to 3 years because of going back to their old unhealthy lifestyle.
Okay.
And because the basal metabolic rate of a person cannot be changed
Correct.
more often than not, unless that person has a complete 360-degree and is exercising like somebody who has completely been possessed. Only
Right,
then
sir.
the BMR has a shift. But otherwise, you have a tendency to regain for sure.
Okay. So one more question is, sir, best time to give this Monjaro or Vigoi in relation to food?
I think you have to take it first thing in the morning, and you
Okay.
have to take it also at a time where you are in the city or close to your doctor, in the sense that suppose I have a patient who is working from Monday to Friday in some other city and comes back to Mumbai only over the weekend.
Correct.
I will ask him to take that over the weekend.
Okay.
If somebody is traveling over the weekend because of work, then I'll tell him to take it on Monday, so that
Correct, sir.
they are close to their doctor and they can reach their doctor if there is a problem.
Right, sir. Dr. Praveen Telias asked, after stopping this anti-obesity drug, they regain weight.
Yes, that is the most logical thing that will happen. Unless you, like I already mentioned, you're on top of your lifestyle and you continue. See, once you start losing weight, say for example, a person is my height, say 170 or 71 centimeters. My ideal body weight should be around 60 to 65 kilos, but my weight is 100 kilos. Okay.
Correct.
I have taken the drug. I have come back to 65 kilos after a year and a half. Okay. And by this time, I have gotten into a habit of exercising regularly and eating a very, very healthy diet and in small portions, because the drug doesn't allow you to eat big portions.
Eat.
Then, if I stop the drug, there is a tendency that I may put on weight. But if I continue in the same vein, I will not put on weight.
Correct, sir.
But the moment the drug is withdrawn, the half-life of the drug, I already mentioned in one of my slides, is 7 days.
Yeah.
The 8th day, all that inhibition that was there in the hindbrain, in the hypothalamus, is all gone. There is no circulating GLP-1. You're on your own.
Right, sir. Sir, can a patient with diabetic proliferative retinopathy can take this Monjaro?
No.
No.
Complete
Yes, sir. That you have told, yeah.
contraindication.
Dr. Mehmood has told it's a very well taken, and Bariatric as well as this GLP-1. There's one more. Somebody has asked for your share your number and this sir, um, your
Yeah.
number and email address, sir.
I have replied with that.
Okay.
So
Yeah.
I will also put it on the chat so that everybody can
Yes.
see it.
Correct, sir.
And if
That's all this, sir.
I hope that all of you have enjoyed this talk,
No,
and
100%, sir. It's good, sir.
I've tried to cover everything possible.
Yes, sir.
If you think that I've missed out on something, feel free to just call me directly, and I can definitely reply to any query that comes to your mind.
Correct, sir. Okay, sir. Sir, good evening to all. As we come to
Thank
the
you. Thank you very
close
much.
of the insightful of 305 webinar, it is my privilege to deliver the vote of thanks on behalf of General Practitioner Association and in collaboration with Jaslok Hospital Research Center. I sincerely thank our speaker, Dr. Jaydeep for a wonderful enlightening session, and your thoughts have truly enriched our understanding of the topic. I also thank all our participants for joining online and making this webinar 305 a success through your presence and interaction. A big thanks to our organizing team, Dr. Dolakia, Dr. Bharat Bhatt, Dr. Ajita Bhosle, and our technical team, Mr. Avinash and Pranav. Thank you once again. Hope to meet you all in our next webinar.